Hello everyone, my name is Tomohiro Kadota from National Cancer Center Hospital East, Kashiwa, Japan. I am specialized in upper GI cancer and corresponding author of this article. Today, together with my colleague Dr. Inaba, I would like to talk about our original article, which was recently accepted in GI and titled Long-Term Outcome After Endoscopic Submucosal Dissection for Entire Circumferential Clinical T1A and 0M0 esophageal squamous cell carcinoma. On behalf of co-authors, we would like to thank GI for opportunity to present our study.
Hello everyone, my name is Atsushi Inaba, first author of this article. It is a great honor for me to have such an opportunity to introduce our study today.
First of all, why did you decide to conduct this study?
Recently, the entire circumferential esophageal squamous cell carcinoma (EC-ESCC) can be resected en bloc using ESD. However, ESD for EC-ESCC has concerns of refractory esophageal stricture and non-curative resection requiring additional treatment. The ESD-EMR guidelines for esophageal cancer in Japan recommend each treatment based on the tumor depth, circumference, and longitudinal extension. In clinical practice, initial treatment for clinical T1A and 0M0 EC-ESCC is selected based on physician's choice, considering risk of esophageal stricture and non-curative resection. The long-term clinical course of clinical T1A and 0M0 EC-ESCC after initial treatment, ESD, surgery, and definitive CRT remains unclear, and there are no clear criteria for the initial treatment. Currently, the guidelines are not always applied in clinical practice, and the initial treatment for clinical T1A and 0M0 EC-ESCC varies among institutions.
From these backgrounds, what is the aim of this study?
We aim to clarify the long-term outcomes after ESD in patients with clinical T1A and 0M0 EC-ESCC compared with those after surgery or definitive CRT.
How many patients were included in this study, and what initial treatment was selected for each patient?
Finally, 59 patients were enrolled. Regarding the initial treatment, 28, 15, and 16 patients underwent ESD, surgery, and definitive CRT, respectively. The study population was classified into 4 groups, Group A to Group D, based on tumor depth and longitudinal tumor length. The initial treatment selected for each group is presented as follows. In Group A, ESD was selected in many cases. Similarly, in Group B, most cases were treated with ESD. In Group C, approximately half of the cases with a longitudinal length of 5 to 10 cm underwent ESD, whereas no cases more than 10 cm were treated with ESD. In Group D, most cases with a longitudinal length of 5 to 10 cm were treated with either surgery or definitive CRT, and no cases more than 10 cm underwent ESD.
How were the short-term outcomes for each initial treatment?
The curative resection, esophageal stricture, and refractory stricture rates were 72%, 79%, and 46% respectively in the ESD group. The other resection rate in the surgical group was 93%. Esophageal stricture rate and refractory stricture rate were 20% and 13%. The CR rate in the definitive CR group was 94%. Esophageal stricture rate was 0%.
How was detailed short-term outcomes of ESD group?
For the curative resection rate, It was over 80% in clinical EP-RPM regardless of the longitudinal tumor length. The curative resection rate was higher for clinical EP-RPM than for clinical MMSM1. For the esophageal stricture rate, it was over 70% in all groups. Moreover, the esophageal refractory stricture rate tended to be higher when the longitudinal tumor length was more than 5 centimeters.
How was the long-term outcomes for each initial treatment?
The 5-year overall survival rate was 92.9% in the ESD group, 86.7% in the surgery group, and 75% in the definitive CRT group. The 5-year disease-specific survival rate in the ESD, surgery, and definitive CR group was 100%, 100%, and 93.3% respectively.
The ESD group showed moderate short-term outcomes with high en bloc and curative resection rate. However, the esophageal stricture rate and refractory stricture rate were higher. The surgery and definitive CRT groups showed favorable short-term outcomes with 93% of ulcer resection and 94% of CR. Regarding the long-term outcomes, the 5-year disease-specific survival was favorable across all treatment groups. Based on these results, how do you consider the indication for ESD in clinical T1N0M0 EC-ESCC?
Group A can be considered the most suitable group for ESD because it has a high curative resection rate and a low refractory stricture rate. In Group C, the curative resection rate was favorable. However, the refractory stricture rate was high. Therefore, if stricture prevention methods are improved, Group C could be the first candidate for expanding the indications for ESD. In contrast, the indication for ESD in clinical MMSM1 cases should be carefully considered. In particular, clinical MMSM1 regions more than 5 cm developed esophageal refractory stricture rate. Therefore, ESD may not be indicated, and surgery or definitive CRT should be selected.
Thank you for your attention.